by thanking our sponsors of the Patient Insight webinar series, Merck and UroGen. And so I'll start by saying that each year, over 80,000 Americans are diagnosed with bladder cancer. Roughly 75% of those are non-muscle invasive bladder cancer. For the newly diagnosed, many questions come to mind. This webinar, Walking Through a New Bladder Cancer Diagnosis, is designed to help you understand what is non-muscle invasive bladder cancer, the risk factors, and the therapies available to treat this type of bladder cancer. To help us with this, we have invited Dr. Ava Saidan, a urologic oncologist at the University of Tennessee Health Science Center in Memphis. She treats all urologic malignancies and specializes in bladder cancer, kidney cancer, and testicular cancer, among other things. Dr. Saidan earned her medical degree at the University of Kansas School of Medicine and completed her urology residency at the University of Alabama at Birmingham. She completed a 2-year Society of Urologic Oncology accredited fellowship at the University of California, San Diego. She is a recipient of Beacon's 2022 Young Investigator Award, and she's a member of the Society of Urologic Oncology, American Urological Association, and Society of Women in Urology. With that, I want to welcome Dr. Saidan for joining us today and hand over the mic for a presentation.
Thank you. Thank you so much for having me today. It's a privilege to be able to speak to you about non-muscle invasive bladder cancer. So as Patricia mentioned, I did receive a YAA grant through Beacon, and that's my only disclosure. So as she mentioned, we're going to talk about some of the risk factors of bladder cancer, then go into the different types, signs and symptoms, and then the testing that goes into diagnosing bladder cancer, as well as some of our first-line treatment options, and then resources and tools. So you can kind of divide the risk factors for bladder cancer into 3 different categories: behavioral, genetic, and environmental. So behavioral, these are kind of lifestyle choices or habits that we make that might increase our risk of developing bladder cancer. Smoking is the leading risk factor for bladder cancer. Cigarette smoke contains carcinogens that goes into our lungs and then into our bloodstream. Then that gets filtered by our kidneys, and the urine that contains those carcinogens sits in our bladder and can damage the bladder cells. Diet and fluid intake. So diets that are low in fruits and vegetables and high in processed meats can increase your risk of bladder cancer, as well as decreased fluid intake. It's thought that if you're not drinking enough water or fluids and you're not urinating often, so harmful things that your body's trying to get rid of kind of sit in your bladder for longer periods of time and can cause damage. Chronic bladder infections and inflammation. So recurrent urinary tract infections can lead to an increased risk of bladder cancer, as well as exposure to certain chemicals in the workplace. So people that work in dye manufacturing, petrochemicals, and rubber production can be exposed to things that can increase their risk of bladder cancer. So some genetic risk factors. Having a family history does increase your predisposition potentially to having bladder cancer. It's not like other cancers where, like, for example, if you have a BRCA mutation, you're at very high risk of getting it, from your parent or something like that. But having a family history, you are a little more pre-inclined to get bladder cancer. There are some inherited syndromes that are very rare, but do exist, such as Lynch syndrome and teratoma syndromes that increase the risk of bladder cancer. And then there are simply some genetic mutations that aren't associated with syndromes that can increase your risk of bladder cancer. And third, environmental exposures. So chemical exposures similar to those ones that are found in certain industries, things that are like in dyes, paints, and solvents. Chronic long-term exposure to those can increase your risk of bladder cancer. Arsenic in drinking water, and then radiation exposure, whether that's environmental radiation like radon gas or radiation therapy, so treatment for other types of cancer, especially cancers in the pelvis, such as colorectal, cervical cancers that might receive radiation. Those can also increase your risk of bladder cancer. And then there are certain drugs that chronic exposure to can increase your risk. Most of these are chemotherapeutic drugs, things that you aren't necessarily taking daily, but there are some out there that can increase your risk of bladder cancer. Now, what are the different types of bladder cancer? For the most part, we split them kind of into two different classes, urothelial and non-urothelial. So the urothelium is the lining, it's the inside lining of your bladder. So this epithelial lining that's kind of in this picture, that's your urothelium. And cancers that arise from that are urothelial carcinoma. And then when you have cancer in your bladder, that's a different cell type than the urothelium. We consider those non-urothelial cancers. So urothelial carcinoma, the cancer that comes from the lining of your bladder, is the most common type. About 90% of cases originates from the urothelium. We divide it into non-muscle invasive and muscle invasive urothelial carcinoma. We'll kind of get into what that means a little later. They can be papillary or flat, so they can kind of stick out like a cauliflower, or they can cover the floor of your bladder like a shag carpet. And then they can be low or high grade. So when you have a urothelial carcinoma, a pathologist will look at it under a microscope and it'll give it a grade, low or high. Low grade tumors tend to be less aggressive. They tend to not progress, versus high grade are more aggressive. They tend to come back and progress into higher stages of disease. Non-urothelial bladder cancers, these are very rare. They make up less than 10% of bladder cancers. The most common ones are squamous cell adenocarcinoma and small cell carcinoma. You'll hear these types of bladder cancer described as variant histology. So, the histology varies from our classic ones. We call it a variant histology. They tend to be more aggressive and they usually require more aggressive treatment. Again, these are the minority of bladder cancer types. So signs and symptoms of bladder cancer. I understand, a lot of people here with us today might already have a diagnosis of bladder cancer or know someone with bladder cancer, but I think it's really important to hammer these home because, it's good to know for yourself, and also what to be aware of in terms of things that could be a sign of even a recurrence of your bladder cancer. So the most common symptom is hematuria, that's blood in your urine. It occurs in about 80 to 90% of bladder cancer cases. There are two types of hematuria: gross hematuria, which is when you can see the blood in your urine, or microscopic hematuria. So that's when your urine looks yellow, but under the microscope, we can see that there's blood in it. Other symptoms include frequent urination, pain or burning with urination, or the urge to urinate. So you get the urge to go and you have to go right away. You can't hold it. Now, a lot of these you might notice overlap with the symptoms of a UTI. So that's important to keep in mind. If you have a UTI that just won't go away, or you keep getting frequent UTIs even after treatment with antibiotics, it's important for you to be referred to a urologist or to be evaluated for bladder cancer to make sure that those symptoms aren't a sign of bladder cancer. So once we're suspicious of you potentially having bladder cancer, or in most cases having blood in your urine, we need to evaluate all the structures involved in making urine, because the blood can come not only from your bladder or your urethra, but from your kidneys or your ureters, which are these tubes that drain your kidneys or drain the urine from your kidneys into your bladder. So the way that we evaluate your kidneys and your ureters is by using abdominal and pelvis imaging. Most of the time, this is a CT scan with contrast. If you can't receive contrast because of your kidney function, then we can get an MRI. Now, the bladder and the urethra are hard to visualize on CT and MRI, so we use what we call cystoscopy. to evaluate your bladder and your urethra. So a cystoscope, cystoscopy is a medical procedure where we use a small camera that's attached to this long, skinny tube to look inside your urethra and bladder. It's gently inserted to your urethra to examine it closely, as well as your bladder. It's done in the doctor's office, and we usually use some local anesthesia, so that numbing medicine inside your urethra to help minimize any discomfort. It is a funny sensation because as we put the scope in, it feels like you're peeing, but you're not. Especially when the scope passes through your sphincter, which is the muscle that keeps your bladder closed. There can be some discomfort there. The whole procedure takes usually less than 5 to 10 minutes. You can go home the same day. You can drive yourself there and back. You might have some mild discomfort with urinating for the rest of the day, especially some burning. That's completely normal. And in my experience, that usually goes away within 24 hours. So you've had some blood in your urine, you go into the office, you've had your cystoscopy, and there's a concerning lesion, or your urologist sees a tumor. So what we do next is called a TURBT, or transurethral resection of bladder tumor. So what we do is we use a resectoscope. That's this instrument you see in this picture. This comes off of our cystoscope, so we can see what we're doing. And it has a loop on here that uses cautery, so kind of a hot knife. And we resect the tumor or the suspicious tissue and send it off to the lab to be examined. We resect all the tumor that we can, and then we cauterize any bleeding. The procedure usually takes about an hour. It can take longer if you have a lot of tumor or if there's a lot of bleeding to control. Most people go home that same day, and depending on how much we had to resect, you may or may not go home with a catheter. And the catheter usually stays in for a few days. It kind of lets your bladder rest while it heals up. Just a brief note, when you have a TURBT, your urologist might recommend that you get chemotherapy at the time of your TURBT. This isn't uncommon. Sometimes after your resection is done, if there's no concern that we've perforated your bladder, there's no hole in your bladder, we might give you some chemotherapy in your bladder that just stays in there for about an hour. This works best for low-grade bladder cancer, especially TA, which we'll get into in a minute what TA is. So when your urologist looks in your bladder, we can't tell you exactly if you have low or high grade or TA or muscle invasive disease, but we can get pretty good at delineating if we're suspicious that it's just a low-grade disease. And in that case, we might give you some chemotherapy in the operating room. So if your urologist suggests doing that, that's very common. And we do it because it's been shown to prevent recurrence, especially in those low-grade diseases. So the purpose of that TURBT is not only to remove tumor, but to also stage it. So the staging is based on how deep the tumor invades into your bladder. So if it's just in this first cell layer, if those cells just kind of look funky, we call that CIS, or carcinoma in situ. The next stage is TA. So this is where there's a morphologic abnormality as well within that first layer. T1 is the cancer has extended from that first layer of the urothelium into what we call the lamina propria, which is this lighter pink layer of tissue. It's the connective tissue that connects that urothelium to the muscle layer of your bladder. And then T2 and T3 are when the tumor's gone into your muscle or the fat around your bladder. Now those are then considered muscle invasive. So for this talk, we're focusing on just these non-muscle invasive stages of bladder cancer. So once we know what stage you are, we then will risk stratify you. So based on the stage of your disease, we put you into a risk group. These are the risk of the disease coming back or progressing. The reason we do this is because the treatment that you'll receive is based on what risk group you are. So this is a really good question to ask your doctor. You might hear them say you have high grade T1, blah, 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 blah. But you ask them, hey, what risk group am I in? Because that's what's going to determine what treatment you're going to receive. So low risk bladder cancer is made up of low grade disease that's TA, so just in that first layer, less than 3 centimeters, so small tumor and solitary. So there's just one low grade, small, not very invasive tumor. Intermediate risk is comprised of those low-grade tumors, but they're a little bit deeper. They might be a little bit bigger, 3 centimeters, or there's multiple of them, or it's a tumor, a low-grade tumor that you had, but it came back within a year. The intermediate risk group also involves high-grade urothelial carcinoma, but it's high-grade that's not very deep, small, and solitary. Then we have our high risk group. So high risk is high grade urothelial carcinoma, that's CIS, T1, large or multifocal. And then there are some very high risk features that will kind of change your treatment, or it'll make us approach your treatment in a more aggressive way because you're at a much higher risk of the disease coming back. So before we jump into the specific therapies, there is a role for a repeat TURBT. So you might think, okay, I went into surgery, my tumor was supposedly resected. Now my urologist is telling me I have to do it again. Yes, this is very, very common, and it's actually a really important part of our treatment for you. So if for some reason we were unable to get all the tumor the first time because there was too much or there's too much bleeding, or if there is a lot of tumor that are very large or in a lot of spots, or if you have a high-grade T1 or a high-grade TA that's very large, or there was no muscles in the specimen, we recommend that you go back for a repeat resection within 2 to 6 weeks of your last resection. Now, this is very important because what we found is if you have high-grade TA disease and we go back into your bladder, 50% of the time, we're going to find that there was more cancer there. Even if we couldn't see it, when we resect the area where the tumor was, 50% of the time, there's still disease there. Then 15% of the time, it will actually be upstaged. So we'll find that it was actually a higher stage disease than we initially thought. Then if on your first TURBT, you have high-grade T1, when we go back in, about 50% of the time, we'll find more disease again. And 30% of the time, you'll be upstaged to muscle-invasive disease. Now, muscle-invasive disease, you'll receive a completely different treatment paradigm that could potentially include having your bladder removed. So you can imagine how important it is that we do this re-resection and make sure that we've accurately staged your bladder cancer.